Current scenario in refractory shock. So I'll call upon to balance this session Dr. Gopinath sir onto the stage. I also request Dr. Balasubrahmanyam and Dr. Anand Joshi to come onto the stage.
I mean, before I start the TRIBATE, let me ask all the learned colleagues and the audience in the this thing, how many of you use methylene blue when you're pushed against the wall, particularly in case of refractory shock? So I got good numbers. Even my con person says that he uses it. So I already won the debate. So there is there any point for me to say anything more? Okay. So anyway, I mean, I didn't expect this from you, sir. I mean, I thought I'll tell you that there's going to be a better way of this thing, but you have already accepted. This will be the outline of my lecture. So we all know from the Eric Angus pictographic what the pathophysiology of sepsis, septic shock leading to organ failures, mods, and death. All the sepsis patients, we know that initially they are fluid responsive. If you look at the Holland Ice 2020 paper, even if you give a fluid, hemodynamics are going to be maintained only for about 10 minutes period. That's the PKPD study that was done in 2020. Then they become refractory to fluids. So you start catecholamines. Then they'll become resistant to catecholamines. Then we are entering into this phase of refractory shock. So what exactly is this refractory shock? I mean, is there any universal definition? There is no universal consensus definition on refractory shock. If you look at this paper by Antonovsky in 2022, got published in 2023, it's a clinical condition characterized by persistent hyperdynamic shock, even though adequate fluid resuscitation, individualized fluid doses, and high dose of norepinephrine more than 1 mic per kg per minute. So we're talking about more than 1 mic per kg per minute, not 0.2, not 0.5. So that is the definition that was concluded after this review. This got published in 2023. Now, what is the incidence of refractory shock? It's about 6 to 7% of your critically ill patients who are having already a shock to develop a refractory shock. That means very minute amount of or meager amount of population. And if they develop refractory shock, the mortality rates are going to be more than 50%. One of the best studies to look at that is the Ethos 3 trial by Khanna sir. What exactly is the pathophysiology? Why are we looking at methylene blue, or what's the pathophysiology if you look at it? I mean, we all know sepsis causes a lot of vasodilation because of overproduction of nitric oxide. So it's your vasopressors have a negative effect on your inducible nitric oxide synthesis. But when they get depleted, okay, your nitric oxide overproduction happens, which gonna stimulate your soluble guanylate cyclase, and then increase the production of cyclic GMP. Thereby, it also decreases calcium entry into the cells, leading to hyperpolarized state, leading to more of vasodilatation. So that's a progressive thing. If you don't have any weapons to counteract this mechanism, your patient is ultimately going to die. You don't have any other refuge for you at this point of time. So what is the management at this point of time do we have? If you look at all the things bottom down, identify, if you find some treatable causes, you treat the cause. Otherwise, you have majorly two major. There are list about 7 to 8, but majorly the things that are said to be about two. One is your methylene blue, and the one is hydroxycobalamin. So hydroxycobalamin, the dose that you need is about 5 grams. At this point in India, it's not available at that doses. So we left out with methylene blue, which is very widely available. Now let me ask you guys again, when you're pushed against the wall and your patient is almost about to die, you have a drug that is cheaper, available, you want to use or you don't want to use. Probably you may save or not. We don't know that. Do you? If I were to be in your place, I will definitely say yes. I'll go ahead and use it. So let's see what is exactly methylene blue. It is methyl thionyl chloride. What exactly it does? it acts by inhibiting both the endothelial nitric oxide synthesis as well as soluble guanylyl cyclase. So thereby the vasodilation can get minimized. So your vasopressor responsiveness or vasopressor requirements are going to come down very significantly. What are the major adverse effects? Probably my Dr. Anand is going to talk. No, you're going to have methemoglobinia, you're going to have hemolytic anemia. You need to evaluate all the patients for G6PD. But the standard literature says that these toxic effects are there only when you have a dose of more than 7 milligrams per kg, where you have paroxysmal methemoglobinemia, causing you decreased clinically measured oxygen saturation. Or you can have a severe hemolytic anemia if your doses are more than 15 mg per kg. But I'm not going to use that dose. Okay, let me see. I mean, where the evidence starts coming around. This is the first paper that got first case report of two patients where Snyder used to increase the systemic vascular resistance. Okay, in septic shock patients, the report is about two patients. That's way back in 1992. Then a lot of PKPD studies happened because methylene blue initially was from the textile industry, then came into methemoglobinemia. Then from 1980s, we have been looking at what is the dose that we need to use. So if you look at this one, I mean, this wing getter study, okay, where they used 4 mg per kg and observed for about 4 hours. And then they found that at 60 minutes, there is definitive increase in MAP, systemic vascular resistance index, left ventricular stroke work index, decreased mixed venous oxygen saturation, decreased lactate. At 20 minutes, you have an increased pulmonary vascular resistance index. At 40 minutes, there is a decrease in PF ratio, which they attributed to the development of methemoglobinemia. But we'll talk. I mean, over here, the dose is about 4 mg per kg. If you look at 2009 Jefferman study, okay, where they used at multiple doses at 1 mg per kg or 3 mg per kg or 7 mg per kg, what they found, methylene blue has got a dose dependent effect on cardiac index, mean arterial pressure, mean artery and pulmonary artery occlusion pressures, as well as left ventricular oxygen function. Now, they also saw that the drug dose dependently increased the gastric arterial blood PCO2 gap. What is the important take home over here? If you use a higher dose, anything above 7 mg per kg, there is going to be a compromised splanchnic perfusion. So these are way back in 1990s and 2000s. Now, I'll tell you the latest literature that got published in 2022, where the Spain group has looked at 262 patients and then they censored 209 patients. They defined shock as non-epinephrine dose more than 0.1 mics per kg per minute and lactate of more than 2. They gave 2 mg per kg of bolus of methylene blue and a continuous infusion of 0.25 mg per kg per hour. They actually divided the entire groups into three groups. One is bolus plus continuous infusion, another is a bolus injection, another is only continuous. And when they found there is a significant decrease in vasotropic inotropic score, vasoactive inotropic score, as well as in the bolus plus continuous infusion group, there is a significant decrease in the 28-day mortality. So probably at this point of time, what I'm worried is the dose is less than 4 mg per kg. Am I having any side effects? Is there any methemoglobinemia developing around? What I found? No adverse effects at all. So with these things, can I say that, yeah, I mean, if I'm using a lower dose, I'm not going to harm the patient. Probably I'm going to have some bluishness, some green color urine, but I'm going to have a much more decrease of vasopressors and I'm going to have a survival benefit. So can I use it? I will say yes. Then when we look at RCTs, there are multiple RCTs. There are close to around 20-25 RCTs looking at methylene blue in vasoplegic patients, majorly in the initial part in the post-cardiac surgical patients. One of the first ones are the Levine et al. In 2004, where they show that the once you added methylene blue, the requirement of vasopressor decreased within the first 6 hours, and it is very much significant. And when they looked at the mortality in people who received methylene blue and who didn't receive methylene blue, it's obviously significantly reduction in mortality. When they looked at the overall incidence of vasoplegia per se post cardiac surgery, it's about 8.8% patient, and they had a worse mortality. But when methylene blue was given in these people, they said things were better. Now let's come to the latest literature. The Puriska study it's a retrospective cohort study which was done in 2020. Now, what is the interesting thing that you look at? Now, over here, I mean, yes, my learned colleague will argue that no, you're looking only at macrodynamics, macro circulations. You are not looking at micro circulation. Now, over here, They looked at the hemodynamic outcome data and the baseline tissue hypoxia related parameters uh, with the ratio of both the arterial content as well as the total ratios. And what they found is methylene blue group has got a better responders. Now, another Indian study that got published in the Indian Journal of Critical Care Medicine in 2023 looked at a total of about 76 patients. They said there is a definitive decrease in mean arterial blood pressure as well as vasopressor dose. And I'm going to end with two interesting meta-analysis. One is by Zhao in 2022 before the IBRARA studies which came in 2023. So now over here, I mean, they have taken 15 studies which included 7 RCTs, and they found that all of them have shown a significant mortality benefit. And when we look at the adverse effects, hardly anything around. Now, this is only seen with people who are in refractory shock, not prior. The definitions of refractory shock are different. Now, the other one is Fernando et al. After the IBRARA study in 2023, which looked at 7 studies, and then they concluded with 6 studies. They showed if you look at short-term mortality, mean arterial pressure, duration of vasopressors, and mechanical ventilation, all of them decreased. And the adverse effects, if they look at this thing, only greenish blue discoloration. So administration of methylene blue may reduce short-term mortality, duration of vasopressors, hospital length of stay, and minimal adverse events. So take home, the dose is about 1 to 2 mg per kg and a continuous infusion of about 0.25 mg per kg per hour. You have a good amount of meta-analysis of the data, less risk of analysis. If you look at, if my learned colleague says that no, I have a risk of anaphylaxis, it's 0.8%. Hemolysis, 8% risk. Risk of serotonin, your patients on refractory shock, hardly they will be on SSRIs. Even if it is there, you need to be careful. So, मेरे पास क्या है? मेरे पास physiologically sound evidence है. It's backed up with a good amount of RCTs. It improves your map, decreases vasopressor requirements, shortens your ICU stay, mortality benefit is there. Hardly have any adverse effects. It's cheap and easily available. So I'm going to tell my colleague that it's never too late. You have to start believe and start using it. But he already said he is using it and he believes it. So my job is done.